So, all right, our MEC Minute for October is going to be on toxidromes. So, what is a toxidrome? Well, a toxidrome, by definition, is a constellation or group of symptoms that are characteristic of a given class of drugs or agents. And we use toxidromes, or we think about toxidromes in patients who may have had a toxic exposure, and then use their associated symptoms to see if or determine what the causative agent may be. And I think it's important for us to be aware of toxidromes, and some of those that we'll talk about you are already well aware of, such as toxidromes associated with opiate use or stimulant use and abuse. But I do want to talk about toxidromes, not just from what you may see in clinical practice on a daily basis, but what you might need to keep in the back of your head so you maintain a high index of suspicion for use of toxic agents as a terrorist act. So, one of the things that's been interesting to me is in England last March or April, they had those two family members who were poisoned with a toxic agent, a nerve gas, and somehow they were able to quickly determine that a nerve gas had been used. So somebody was astute enough to identify that these two patients had symptoms that were similar and unusual to experience in the everyday community, and thought that a toxic agent may have been at play. So what are we going to talk about as toxidromes? We're going to talk about some common ones, and we're also going to talk about some less common ones. So we're going to talk about the clinical symptoms that are caused by various toxins. We'll talk about stimulants. We'll talk about sedatives, hypnotics. We'll talk about opioids. Probably not talk a lot about that because we see that on a daily basis. We'll talk about the anticholinergics. We'll talk about the cholinergics, and that's where a lot of the nerve agents are. They're cholinergic medications. We'll talk a little bit about hallucinogens, and I may mention a word or two about hypoglycemics, although hypoglycemia we see on a regular basis, and we do a lot of blood sugar screening for hypoglycemia on anybody who's got an altered level of consciousness. So those that are common are stimulants and the sedative hypnotics, the opioids, the anticholinergics. Cholinergics could be common, particularly if you work in a community that has a lot of farming, because a lot of the pesticides used in the field are cholinergics or similar to nerve gas agents. We'll talk some about hallucinogens. We'll talk about bath salts, which have been issues in the past. They've seem to have gone away, but every now and then they pop back up again. Talk a little bit about excited delirium. That's predominantly a psychiatric problem associated with or compounded by use of stimulants. And excited delirium is a deadly disease if not quickly identified and treated. And we'll talk a little bit about the toxic alcohols, mostly methanol and glycolene, propylene glycol, both of which you may see in the field and need to be rapidly identified and treated, particularly at the hospital. We'll talk some about chemical weapons like the asphyxiants and nerve agents. We'll talk a little bit about the blister agents and some respiratory tract irritants. So from the stimulant side, we call these sympathomimetics. Those that you may be used to seeing include cocaine and amphetamines. Caffeine is one. Patients who take too many decongestants, or in the years past when ephedra was out there as a medicine, as a stimulant for people to lose weight or not fall asleep. Fortunately, ephedra has been banned by the FDA because of significant side effects. Symptoms that you may see with stimulants include tachycardia. Patient may be hypertensive. They may be sweating. They may be tremorous. If they get enough of the stimulant, they may have seizures. They could be very restless. They could be having active hallucinations. And they could also have excessive pressured speech where they just ramble and talk incessantly. And if it's a significant enough exposure, you can see an MI. Patients who use cocaine can have ST elevation MIs. What are you going to do for them in the field? Well, if they're hyperthermic, you cool them down. If they are delirious or agitated, we use benzodiazepines or Versed to settle them down. We use benzodiazepines in the emergency department for cocaine overdoses, particularly if they're having cardiac symptoms. And then we hydrate them because often patients who are overly stimulated may be dehydrated just because of their hyperactivity. Talk a little about sedative hypnotics. Benzodiazepines are out there. You also see them in sleeping pills. Some of the barbiturates are also sedative hypnotics. Chlorohydrate, which is an old world drug we used to use, particularly in children for sedation, you may see on a rare occasion if somebody has been prescribed it or if they've been hoarding it from years past. These patients tend to be sleepy and confused. They may be ataxic. You ask them to walk and they're unsteady. And they may have episodes of apnea if they have enough of an overdose. So benzodiazepine patients or patients who overdose on benzodiazepines can have respiratory difficulties. If they mix the benzodiazepine with alcohol, that sedating effect and the respiratory depressing effect is even more pronounced. So always be aware of a patient who's mixed benzodiazepines and alcohol. For these patients, for what we do in the field, we could intubate the patient, give them ventral support if necessary. You could use sort of a BiPAP if you need to. Flumazenol is a medicine that can be used to reverse benzodiazepines. It's also called Romazicon. We have carried it in years past, but we've had such infrequent use that it just isn't used in the field anymore. In the emergency department, I may use it once a year, if that often. I generally, if the patient is that sleepy, I just let them sleep it off. If they need ventilatory support, then I put them on a ventilator. Opioids, we are overly familiar with. We see those in a lot of overdose situations. These are the patients that we give Narcan to. And think about morphine, fentanyl, hydrocodone, oxycodone, heroin, and hydromorphine. There are other forms of fentanyl out there like afentanyl and so on. But we all recognize these symptoms. These patients tend to have respiratory depression. Their pupils tend to be very small, and they may be bradycardic if they get enough or too much. These patients we're going to give naloxone to. We intubate if is necessary. So if you give them Narcan and it's still not working, then we'll put the tube in and intubate them. I think the important consideration is that we use naloxone for the purpose of supporting respirations. I do not advocate using naloxone as a diagnostic tool. So if you think the patient may be an overdose on an opioid, but they're breathing normally, I would save the Narcan and transport them to the hospital. My concern is that if we give them Narcan, we tend to give them too much, and we go from a patient who's overdosed to a patient's in acute withdrawal. I think we should just worry about maintaining adequate respirations. Talk a little bit about anticholinergics. These are medicines like Benadryl and some of the other Benadryl-like antihistamines. Other medications are out there that have anticholinergic-like effects. Amitriptyline is an example. It's a tricyclic antidepressant. So things like nortriptyline, amitriptyline, which is also Elavil, those types of medications can give you anticholinergic effects. These patients tend to be flushed and hot. They may have a fever. Their skin and mucous membranes are dry. They may be complaining of symptoms relating to urinary retention because the anticholinergic blocks the motor effectiveness or the effectiveness of the muscles of the bladder, so the patient simply can't void. These patients may become agitated. They may hallucinate. They will have dilated pupils, not pinpoint pupils, and their vision may be blurred. Sometimes you'll see this in patients who have been abusing gypsum weed for reasons to try to get high, but if they take too much gypsum weed, they can have these severe anticholinergic effects. These patients, if they're agitated, need to be sedated, you can give them benzodiazepines. If they're hyperthermic, you need to provide cooling. If the patient appears dry, is tachycardic, you can give them IV fluids and give them a bolus. Some of these patients need additional supportive management. They may need a Foley catheter to drain their bladder, but that's something that we would do at the hospital. So you may see some anticholinergic effects out there. Benadryl or the over-the-counter antihistamines is the most common. We don't see as many patients with tricyclic antidepressant overdoses anymore because we tend to be using other antidepressants like Zoloft and so on, which are not anticholinergic medications. One comment about the anticholinergics is, particularly if you're worried about a tricyclic overdose, is watch your 12-lead electrocardiogram. The most common finding you'll see is tachycardia. If the patient is a TCA overdose and is hypotensive, or tachycardic, give them a fluid bolus. Watch the QRS duration, because if the patient starts developing widening of the QRS after a tricyclic overdose, they may develop further arrhythmias, and they may develop PVCs. If the patient's a TCA overdose and they develop ventricular arrhythmias, the treatment of choice is intravenous sodium bicarb. There are times at the hospital we'll put patients on a bicarb drip if they're a TCA overdose, based on what their QRS duration looks like on the 12-lead. Comment or talk about cholinergics. We'll talk a little bit more about the nerve agents, but nerve agents are cholinergic medications. The things that you'll see commonly are the organophosphate insecticides and the carbamates insecticides. So if you have a child who gets into 7 or one of malathion, any of the other insecticides, or it could be an adult who has an intentional overdose on these medications, you have to think about the cholinergic effect. I just want to talk briefly about how these medications work. If you look at how nerves conduct the signals across the nervous system, a chemical called acetylcholine is released by the end of one nerve, and it crosses the gaps or synapse to the next nerve, and when it gets to the other nerve, it stimulates more electrical current, which is what the nerve activity is. Acetylcholine is broken down by something called acetylcholine esterase, and if you break it down, it's going to form choline and acetate. The cholinergic medications are acetylcholinesterase inhibitors, meaning that you don't get breakdown of choline and acetate, so you have an accumulation of this neurotransmitter acetylcholine, and you get overstimulation of the nerve that's starting the new signal. So these drugs can be very dangerous and can give you various types of symptoms. These symptoms tend to fall into that acronym called SLUDGE, which is salivation, lacrimation, urination, diarrhea. They could have GI upset, or gastric distress, and emesis. They could also be bradycardic, and they might have episodes of bronchospasm and bronchoconstriction. So if you have a patient, or you have a group of patients who have all similar symptoms of very sudden onset, you might think about, is this a cholinergic crisis, or has somebody gotten into a organophosphate insecticide or other type of insecticide, or be a victim of bioterrorism. So if you're thinking back again to those 2 people in London in last spring, they must have had symptoms of a cholinergic crisis, and I imagine they had sludge symptoms as well. So how do we deal with these patients? Well, patient decontamination is important. If you have reason to think that there's contamination of the scene, then you also need to wear PPE to protect yourself. But patient decontamination is important. If it's a powder, brush it off, wash it off if you have to. These patients may require intubation and ventilatory support. We use 2 drugs specifically for this. This is where your duodote kits come into play. Atropine is what we use initially. It helps block some of these side effects. It doesn't really fix the problem of acetylcholinesterase overactivity. What it does, though, is it blocks the effect of this excessive amount of chemical. So we give as much as necessary, particularly to manage the cardiopulmonary symptoms, so that we give the patient enough until their bradycardia resolves, and that bradycardia can be significant. So give enough until their bronchoconstriction resolves, and we can also follow their GI symptoms as well. When we have to give patients atropine for these cholinergic poisonings, typically it's much more than you're used to giving. So if you think the patient's overdosed on organophosphate pesticide and you think they need atropine, usually we start at 2 milligrams and then give more as we need to. Pralidoxime, or 2-PAM, is the second drug we give, and that is to help there be increased improved production of acetylcholinesterase, and we have to give that fairly quickly because some of the chemicals, particularly those used for bioterrorism, can really attach to the enzyme that we want to preserve, and it basically the attachment is irreversible, and the pralidoxime may not work if we hold off on giving it. And I'll talk a little bit more about nerve agents in a couple slides. Hallucinogens, we may see some out there. LSD is the one we all think about. PCP or phencyclidine seems to be having periods when it comes back. Ketamine has been kind of something we've seen in the past. Now we use it for pharmaceutical reasons. These patients tend to be hallucinating, anxious. They may be dysphoric, meaning they're just they seem happier than they should be. They may be hyperthermic, and they may have dilated pupils. For these patients, we tend to provide supportive care. We sedate if needed with Versed. Some of these medications can be bad enough or give side effects of seizures, in which case we have to give them a midazolam for seizures. One of the medications that are chemicals we've had trouble with in the past are the bath salts. They have an effect similar to amphetamines or stimulants. They're a mixture of medications, and they're structurally similar to ecstasy and methamphetamine. They may be labeled as not for human consumption, but we know people do consume it. It can be taken orally, it can be injected, it can be taken rectally. Typically, onset of symptoms is in 30 to 45 minutes, and the effect can last for up to 7 hours. We've had some patients at the hospital where they've had kidney disease, and their clearance of these medications is delayed, so they have ongoing symptoms, particularly agitation, for days because they simply can't clear the drug out of their system. These patients tend to be euphoric. They may have increased energy. They be hyper alert. They may be aggressive. They may be outright psychotic. They typically are hypertensive and tachycardic, and they may be hyperthermic. They may also have some symptoms of concern to them, such as chest pain, tremors, and headache, and they may have insomnia or outright paranoia. There is no antidote for these medications. We treat them with ketamine and midazolam if they're severely agitated. If they are having seizures, we'll give them midazolam in the field. If the patient is really hypertensive at the hospital, we'll start them on some antihypertensives. Sometimes they're so agitated that they are hyperthermic, in which place we'll provide cooling mechanisms to them. I mentioned earlier excited delirium. I think this is something that we all need to be aware of, and because it can be a fatal disease. Sometimes when you hear about people who die while in police custody, it's because they've been arrested for symptoms of violence, but they're truly suffering from excited delirium. It's not recognized, and they die. Typically, the patient has some underlying psychiatric problems, and they mix it with bath salts, methamphetamine, or cocaine, and they develop acute severe delirium. They may be hallucinating. They may have trouble speaking in ways that we understand. They tend to be disoriented and hyperthermic. Like patients who are on PCP, they may be insensitive to pain. And they may exhibit severely violent behavior or behavior that's just outright bizarre. These patients are at risk to develop cardiac arrest. So if you're in that circumstance, we have to think about things such as hypoglycemia or head injury, but these patients typically are hyperthermic, whereas head injury patients or patients with just straightforward psychiatric illness without excited delirium typically don't have hyperthermia. These patients can develop acidosis because of their agitation. We're going to treat them aggressively with ketamine and midazolam. If possible, or if needed, we'll use restraint, but often restraint helps precipitate cardiac arrest, so we prefer to use chemicals to get these patients cooled off quickly. And at the hospital, we tend to add antipsychotics. But when we look at the history of ketamine for use in EMS, one of the first indications for ketamine use by EMS was patients with excited delirium. If the patient's hyperthermic, we're going to get them cooled off. We're going to get the clothes off. We're going to use either misted water or ice packs or cold saline. We will check for acidosis by doing blood gases on these patients, and we'll treat the acidosis with fluids and sodium bicarbonate. We don't expect you to do sodium bicarb in the field, but if the patient is agitated and you think they are excited delirium, you get them calmed down with ketamine, give them IV fluids and a fluid bolus if you have an opportunity to do so. I just want to talk a little bit about toxic alcohols. The reason I do this, these two alcohols, methanol and ethylene glycol, are extreme poisons, and it doesn't take much to have an adverse effect on people, and they are common. So you'll find them in solvents and cleaners. Sorry for the background noise. They are present. Ethylene glycol is in antifreeze, and if these substances are available, some people will ingest them as a substitute for ethanol or alcohol. And sometimes they're taken intentionally for self-harm. And once in a while, there's somebody who thinks it's funny to put ethylene glycol, which can taste sweet, in somebody's coffee, and the patient drinks it inadvertently and ends up with ethylene glycol poisoning. The reason these things are poisonous is because they're converted into byproducts that are dangerous to the patient. Typically, though, when they're first ingested, the patient may be appear a little intoxicated as if they've been drinking regular alcohol, and they may have some mild abdominal pain. Later in the course of their illness, they may develop hypotension, hypothermia, seizures, and coma. If it's methanol, they may develop blindness, and blindness may be one of the initial presenting symptoms. And if it's ethylene glycol, they may develop renal symptoms such as flank pain. They may have blood in their urine, or they may stop making urine. Both of these substances in themselves are not toxic. The problem is they're quickly absorbed from the GI tract, and they're metabolized into chemicals that are poisonous to the patient. And it doesn't take much of a dose to make a toxic dose. So for both these substances, about 1 gram of chemical per kilogram of body weight is enough to be toxic. So, for an average person, 70 grams, which is about, 2 or 3 ounces, may be enough to be toxic. The toxicity for methanol is it forms something called formic acid, which causes blindness. Ethylene glycol is metabolized into oxalate, which is a crystal which will precipitate in the kidney, causing kidney failure. And both will perform metabolic acidosis. One of the sickest patients I ever taken care of was a patient who came in about a half hour after ingesting methanol, and he was severely acidotic. We went through every vial of sodium bicarbonate in the emergency department and still could not reverse his acidosis. He ended up dying shortly after admission. For these patients, though, ABCs are always important. Airway needs to be maintained, and if a patient needs ventilatory support, we provide it. We will give sodium bicarb at the hospital. We do it even though the literature doesn't greatly support it, but we do it because these patients are profoundly acidotic. Fomeprazole is a medication that we now have available. It's given intravenously, and it helps prevent the toxic metabolites from being formed by blocking metabolization of methanol and ethylene glycol, so they can be then secreted in the urine. And in the past, we would use IV alcohol or ethanol before we had the other antidote. We would give that IV because it would competitively compete with the enzymes that break these other poisons down into metabolic poisons. And then some patients are candidates for dialysis. We tend to have a low threshold for dialysis in these patients. We get nephrology involved early because we just need to get this out of their system. A couple words about toxidromes and weapons of mass destruction. Again, I alluded to what happened in England, and I think it's amazing that somebody picked up on these poisons being used. There are 4 big toxidromes that we have to think about. One has to do with asphyxiants, some of which you're readily aware of. Carbon monoxide, cyanide, hydrogen sulfide is an asphyxiant. I know there's some risk of that, particularly in manure pits and other closed spaces where hydrogen sulfide may be. I can remember shortly after I moved to Columbus, we lost a couple of firefighters, I think it was in Pickaway County, because of hydrogen sulfide in a manure pit, and the rescuers went in without an SCBA, and they were overcome and died as well. You can also think about low oxygen in a closed space, although that's usually not due to a weapon of mass destruction. We also talk about the cholinesterase inhibitors, the pesticides, sarin gas, VX, and the others. There are those respiratory tract irritants. They've been using some of those over in Syria, such as chlorine gas, ammonia, phosgene, and then some of the riot control agents, such as, somebody's been maced. And then there are the vesicants that are really the old world chemicals, but still are being tried every now and then by terrorists. I think even Saddam Hussein used them against Iranians, and those are sulfur mustard and the lewisite. There are also other agents out there that are less common but have been used. Opioids, nebulized or aerosolized fentanyl or afentanyl. That's what the Russians used in that theater in Moscow to try to break the standoff between terrorists and law enforcement. Sometimes anesthetic agents can be used, and then botulinum toxin can be aerosolized and put out into a public space as a weapon of mass destruction. I've got a slide here that pretty much has talked about where these things have been used. So just about everything I put on the list has been used somewhere as a potential weapon of mass destruction. So all of these, there's some even on here that I haven't talked about and which I probably would never recognize if you brought them up. There are also some initial symptoms that you can think of, and it has to do with timing of how things happen. So the nerve agents tend to happen quickly once patients are exposed. Primary symptoms are mental status changes, fasciculations, weakness, and paralysis. You will see some increased secretions, and you may see some shallow respirations. The terminal events tend to be convulsions, cardiac arrest, respiratory arrest, and coma. The asphyxiants, those patients tend to have respiratory distress. They may have seizures and coma. Eventually develop cardiopulmonary arrest. Opioids, the initial symptoms tend to be confusion and small pupils, and then as symptoms progress, the patients develop respiratory depression and eventually coma. The anesthetic agents tend to be confusion and bradycardia and slower respirations, eventually with sedation. The anticholinergics tend to be confusion and disorientation. Again, their pupils tend to be dilated, not pinpoint, and they tend to have a lot of dry skin and complaints of dry mucous membranes. The vesicants, the blister agents, they tend to have mucous membrane irritation first, so runny eyes, sore throat, nasal irritation. Then they'll develop some coughing. Again, that's mucosal irritation of the lungs and bronchi. And with enough of an exposure, they'll develop blistering rash of the skin. And as symptoms worsen, they can develop tremors and comas. The caustic agents, such as acids, they tend to have a lot of skin irritation and eye irritation and coughing, and those patients typically have a strong desire to escape because these medications or agents tend to be very irritating from onset. Some of the riot control agents, like mace, again, it's respiratory and eye irritation, and then centrally acting upper airway agents, those tend to be more things like phosgene and some of the other irritating gases, and those or actually phosgene is more of a lower airway. Upper airway is more like ammonia and chlorine, and those patients can have increasing respiratory symptoms and lung injury if they're in a position where they can't escape the gas. Phosgene is more of a lower airway stimulant. They talk about phosgene having that smoke odor of newly mown grass. It doesn't have much irritating effect on the upper airways, so patients can be around it and have significant exposure and not know it, but then eventually develop irritation, inflammation of the lungs, and develop pulmonary edema and respiratory distress. Botulism is something we have not seen as a gas yet. I think of the botulism cases we had in Lancaster, similar symptoms. We're talking about patients who have made trouble swallowing. They may have some trouble with their vision. They may see double vision. They may have some funny symptoms involving their face first. So initial neurological symptoms tend to be in the face and then work their way down the body. Eventually, patients who have a botulism exposure develop respiratory arrest if it goes untreated because the respiratory muscles just can't work. If we're just looking at clinical features with asphyxiants versus the cholinesterase inhibitors or the nerve toxins versus the irritants. Carbon monoxide is the most common asphyxiant we'll see, although cyanide is out there. It is a metabolic poison, so these patients tend to develop hypoxia and cardiovascular and CNS complications. Mild symptoms typically are headache and fatigue. More severe symptoms are altered mental status and cardiac arrest. The cholinesterase inhibitors, I think it's much more likely we're going to see it as a pharm exposure, but it can be used as a nerve agent. And these patients tend to have those sludge symptoms, and we're going to look out for that and treat them with the atropine and 2-PAM. The respiratory tract irritants, chlorine and ammonia are probably the most common. Ammonia is used commonly in manufacturing and in the farming industry. Chlorine is in the same fashion. We've had some accidental chlorine gas leaks in this area over the years. Chlorine can also be used as a agent for as a weapon of mass destruction. Phosgene is also used in production purpose, but is also more likely to be used for terrorist events because it is less irritating initially than chlorine and ammonia, which patients tend to run away and flee. These patients tend to have trouble with nasal irritation, lung irritation, cough, eye irritation, and the treatment for these patients is generally supportive in removing them from the source of irritation. The vesicants, like the mustard gas and so on, have no real purpose for legitimate manufacturing, and you're not likely to see them, with the exception of some of the mustard agents that may be used as part of chemotherapy. But the risk of these patients, of this drug to other people, is very low. The pharmaceutical industry controls them quite well, and even in the hospital or oncology pharmacies, these medicines are handled in a hood, and they're very strictly controlled, so the likelihood of somebody being exposed is low. They tend to have eye injuries and blistering of the skin. They can have severe irritation of their airways, and if it persists, people can develop significant lung injury and die from the exposure. I have one last slide regarding toxic agents and weapons of mass destruction, and it really has to do with what we've got highlighted in the red section. And these are the agents that really require rapid identification because treatment has to be given quickly as well. So, the initial presentation of somebody who has muscular tremors, they have a lot of lacrimation, vomiting, diarrhea, that sludge constellation of symptoms. That's probably a nerve agent, and we need to get them treated with atropine and pralidoxime, and we need to get them decontaminated as quickly as possible. Patients exposed to these chemicals can die within 10 to 15 minutes, if not quicker, depending on the amount of exposure. Patients who may be exposed to asphyxiants like carbon monoxide or cyanide, they tend to be apneic or be gasping. They will have collapse. They may have seizures, and they may or may not appear cyanotic. These patients need oxygen therapy if you're worried about carbon monoxide. If you're thinking about cyanide exposure, then we need to treat them with our cyanic kits. It's entirely possible that if we have a mass casualty event with cyanide, we won't have enough antidote immediately available to treat the patients. But you always have to think about that. The third time-critical one is opiate agents. Again, if it's being nebulized or aerosolized in a circumstance that can be anticipated or patients may be exposed, and particularly in a closed space, think about the patients who are apneic or they're not breathing well. They have small pupils and they may be sleepier than expected. These are patients who need to be treated with Narcan. I'm not going to go through the others. I think you can take a look at it. I'll give you a couple minutes to look at the slide. But there are other agents out there that we need to think about. If you have an interest in this slide as a handout, let me know, and I can send it to you via email. So that's it for this month. I appreciate your time and attention. I tried to bring you up to speed on a lot of these different toxidromes. If you, again, have any questions, please post them on Workplace, and I'll do my best to answer them. Thank you.